Dr. Hesch, a physical therapist at the Hesch Institute in Aurora, Colorado. And this is an interesting case because there are several parts of Becca's body that are very rigid, and that's actually incongruent with her body type. And she's going to describe for us her IT band syndrome briefly, and then I will demonstrate what my findings are. Go ahead.
So I started having IT band pain when I was training for a marathon about 10 years ago. Started around mile 17 and then continued until I finished the race. After that, I went through 3 months of physical therapy for my left IT band and have not really had any problems since, although I haven't been doing any long running until now. I'm training for 2 half marathons that are coming up in the next month or so. And I started when we reached mile 10. Having pain again in the opposite leg.
And you've had a history of IT syndrome for how many years?
About 10.
About 10.
And so I would never run past about 3 miles because that's when I'd start having pain and I'd stop.
Got it.
But at this point I've actually started being able to run up to 5-6 miles and had no pain until we did it was either 9 or 10 mile run, and then it came back.
Want some free advice? Those 2 marathons? Mm-hmm. Don't do them on the same day. Half marathons. All right. So here's what we find with your body, ignoring what I find in the pelvis and above. We'll film that separately. But you certainly do supinate in both feet. And as a soccer player, that's a deceleration sport, right? Mm-hmm. Your ankles, given your body type, in my opinion, should dorsiflex to about plus 15, plus 20 degrees, and you're at neutral. So with multiple decelerations, your talus is positioned in slight plantar flexion, and it doesn't have the ability to go back up unless we treat it with a passive maneuver. Mm-hmm. This inhibits strength of your everters, which I'll demonstrate shortly. Your subtalar joint has lost movement. I can invert it, okay? I can adduct where the front of the heel goes medially. I cannot evert you. I don't think we're even at neutral. And I cannot externally rotate the foot, which they also call abduction with a B, okay? In response to that, the fibula have shifted downward, and the bottom of the fibula has gone forward, and the head has gone backwards. So both feet are quite similar. I can't spring this lateral malleoli posteriorly, but I can get some give. Do you feel that give? Mm-hmm. Okay, so I can get some anterior give. The fibular head is so restricted I can't posteriorly glide rotate it, and I can't anteriorly rotate it either, okay? So that would make your MCL very tight, and so just note the tension in this ligament, and then we'll show you this tension after we treat, okay? And of course you said if you place your hand here, that kind of describes where your symptoms are, okay? So let's go ahead and evert this ankle. So you're going to lift it up and out, okay? And hold it there, and don't let me break it, okay? And you can just see you've got a powerful body. Obviously you work out. You can see that tib anterior just pop out. Dorsiflex, pull straight up, straight up, straight up, okay? So there you can see that gorgeous outline. I think I'll pay money to get one of those, okay? And I can't break that with 2 hands. Okay, let's go into inversion and dorsiflexion. Just powerful. I can't break that, but you could see how easily I could break that everter. On both sides I could do that. Okay, now I want you to internally rotate the hip. Just hold it right there, okay? And don't let me pull it out on the count of 3. 1, 2, 3. Gosh, you're weak. I was hoping you'd be stronger on this side and that I could show it dramatic on this side, but no. Okay, this side, your hip rotator on the left goes to 45 with a soft end feel. Your IT syndrome is greater on the right. You are tight with respect to your hip rotators. I can get you to about 30, maybe 35, but then there's a hard end feel. So I want to gain motion there. But hold that in rotation, hold the hip in rotation, 1, 2, 3, don't let me derotate it, it's so easy. Okay, so what we have is bilateral. We have a supinatory pattern in the ankle joint and in the subtalar joint, which locks out midfoot. There's just no pronation in this midfoot, so you probably just hyperpronate here. You're probably beating up, I haven't looked underneath that first ray, but you're probably really slamming hard on that. Mm-hmm. So my goal for care is to increase hip internal rotation, okay, and to restore normative supination throughout the ankle complex, which also includes the subtalar joint, where the calcaneus articulates with the bottom of the talus, and the same for the superior tib-fib joint. And as we then work on the pelvis, we will relook at your hip, your weak hip rotators, and see if we can change that. Your external rotators are probably powerful, so let's rotate externally, okay? And at the count of 3, do not let me rotate that in. 1, 2, 3. So yeah, you kick in a lot. You bring in much, because that's where you live. So it would make sense that that's where you're strong. So I'm going to stop filming here, and then we're going to treat your foot and ankle, and then we'll film your response to that.